This short video aims to present the current guidelines from the third trimester ultrasound. The appropriate usual timing is from the 32nd to 34th week. We will base this on the recently published recommendation by the ISWAG in year 2024. These recommendations represent the guidelines validated by obstetricians. Principal indication of the third trimester ultrasound are the evaluation of the fetal viability, then the fetal presentation to rule out breech presentation. One important point is the fetal growth, trying to diagnose the small for gestational age and the large for gestational age. We have to quantify the amniotic fluid volume using the deepest vertical pocket or the amniotic fluid index. The placenta location is also very important, needing sometimes an endovaginal approach if the placenta is low inserted. Finally, the morphological evaluation allow to discover malformations that had not been diagnosed earlier. The place of this third trimester ultrasound is related to the amount of resource. But it has been proved that this late ultrasound didn't diminish the neonatal mortality. Gestational age at the third trimester ultrasound is dependent on the objective. If we want to optimize the fetal anatomical evaluation, we will do it earlier at 32 weeks. In case of suspicion of abnormal growth, then we should delay it at 35 to 36 weeks. There are the recommendations of ISWAG guidelines adapted to the third trimester ultrasound. Biparietal diameter, head circumference, abdominal circumference, and the femoral length. They can be measured routinely for the assessment of the fetal size and weight. The technique used is the same that we used during the second trimester. These parameters allow the fetal weight estimation according to the Hadlock's formula. The definition of large for gestational age is an estimated fetal weight above the 19th centile, or an abdominal circumference above that percentile. Macrosomy is a fetal weight above 4,000 grams or 4,500 grams. The sensitivity for predicting neonatal macrosomy is only 50% and 22% for predicting shoulder dystocia. The recommendation screening for large for gestational age in the general population be more accurate when the examination is performed at 36 weeks rather than 32. And health professional should balance the benefit of induction of labor for perceived macrosomy with respect to shoulder dystocia and fracture, again the potential adverse effect of early term delivery. The definition of small for gestational age is an estimated fetal weight under the percentile 10 or an abnormal circumference under that percentile. Fetal growth retardation is a fetal weight estimation under the third percentile and abnormal fetal Doppler. The sensitivity for predicting neonatal weight under the 10th centile is only 38% and 54% for neonatal weight under the third percentile. Screening for SGR in the general population is more accurate when the examination is performed at 36 rather than 32 weeks. Estimation of fetal weight and abdominal circumference can be used to screen for small for gestational age with similar performance. The prevalence of fetal abnormalities diagnosed during the third trimester is around 3.7 per thousand. 3 major abnormalities are discovered. Half of them are urogenital, then cerebral malformation and cardiac abnormalities. The benefit of this late ultrasound can be to orientate the patient towards an appropriate level of neonatal care hospital. It allows also to discuss and counsel the parents about the impact of the malformation. In case of pathology, prenatal analysis can be performed. Finally, in countries allowing late termination, the parent can take this difficult decision. Morphological assessment of the third trimester ultrasound involve a precise analysis of the aspect of the head and the brain, the morphology of the cardiac structures, the appearance of the thorax, the chest, in particular the diaphragm, to analyze the abdominal contents, and finally the urinary system. Really, the localization of the placenta is very important for excluding a placenta previa. In case of low-lying placenta, it is recommended to perform an vaginal ultrasound in order to precisely analyze the cervical internal os. We should remember that vasa previa could be diagnosed. A woman with placenta previa and a prior cesarean birth or uterine surgery should be considered as a potential case of placenta accreta and managed in a center with experience in the surgical management of morbidity adherent placenta. Then, for the amniotic fluid volume, the deepest vertical pocket is preferred over amniotic fluid index for diagnosed isolated oligoid rhamnus and is associated with fewer indication of labor while having similar perinatal outcome. In case of detection of polydramnios, we should use the amniotic fluid index. In conclusion, even though it is not recommended in most countries and it does not alter neonatal mortality, the third trimester ultrasound has many indications. In particular, it clearly allows an improvement in the neonatal care of the infant.